Good afternoon, everybody. Thank you for joining us. I would like to welcome you all to today's webinar, Stimulant Use, Current Trends, Impact on the Brain and Body, and Implications for Treatment. At this time, I would like to go over some housekeeping items for today's webinar. We would like to encourage you all to participate in today's webinar via two methods. If you have questions for our presenters or are experiencing any technical issues, please use either the chat box or the questions pane to communicate your questions. Your questions will be given to and answered by our presenters during the Q&A portion of today's webinar. Throughout the webinar, all participants will be on mute. Following the webinar, you'll receive the evaluation and information about receiving your continuing education credits. This webinar is approved for 1.5 PCB and/or NADAC credits. You can also request a general certificate of attendance free of charge. I will go over all of this at the conclusion of the webinar. At this time, we are going to do one poll question. We would like to get a picture of our audience familiarity with stimulants. The questions will appear on the screen as an interactive poll. I'm going to give everybody just about 30 seconds to answer the poll question. All right, sorry about that, everybody. It took me a second. But our question is, what is the percentage of your patients that use cocaine and/or methamphetamines? So we have anywhere between less than 10%, 10 and 25%. We have 25 to 49%, and then we have 50% or over, or you don't know. So I'm just going to give everybody that's on just a couple more seconds to answer, and then I'll go ahead and share those responses with the group. Okay, and now that we have our results, you should all be able to see them now. So we do have quite a few people that were able to answer. We had 104 out of 135 of our participants that answered. So thank you so much for participating. I'm going to finish our housekeeping right now, and then we will move on. We appreciate everybody for interacting with us. And like I said, all participants will be on mute, but please make sure that you use your questions pane or the chat box to submit questions for our presenters during their presentation. I would now like to introduce our presenters, Beth Rakowski and Tom Faris. Tom Faris is the co-director of UCLA's Integrated Substance Abuse Programs and co-director of the SAMHSA-supported Pacific Southwest Addiction Technology Transfer Center. Beth Rakowski, MPH, is the director of training of UCLA and co-director of the PSATTC. Dr. Faris and Ms. Rakowski co-chair the ATT Stimulant Work Group with Gene Pulvermacher from the Great Lakes ATTC. And that is everything that I have for now. So Tom and Beth, I will turn things over to you.
Thank you so much, Jessica. Hi, everyone. Good afternoon or good morning, depending on where you are in the country. It's exciting to be here with you today to discuss stimulant use and the things that we've learned about it in the work that we've done through the Addiction Technology Transfer Center network. Neither Tom nor I have any financial relationships or commercial interests to disclose for today's presentation. And I forgot to turn on my camera, so I'm gonna do that now. Sorry about that. Okay, so Jessica reached out to us a few months ago to inquire if we would be willing to do this talk. And of course we said yes, because we wanted to get the word out about a new curriculum that we had developed. So Jessica, thanks very much for inviting Tom and I to do this presentation. I'd also like to acknowledge the ATTC Stimulant Work Group. This is one of several components that was developed through about a 2-year process, and you'll hear more about the larger curriculum in just a few minutes. So for those of you who may not be familiar with the ATTC network, the network has been around since the early 1990s, and it is funded by the Substance Abuse and Mental Health Services Administration. And really the goal of the ATTC is to provide training and technical assistance to substance use disorder treatment and recovery providers located across the US. So currently the network is comprised of 10 domestic centers that follow the HHS regions. And so Tom and I are the co-directors of the Region 9 ATTC based out in the Pacific Southwest. Our home office is UCLA. There's also two population-based ATTCs, one of which focuses on American Indians and Alaskan Natives, and the second focuses on the Latinx population. And then there's a network coordinating office that's based at UMKC in Kansas City. And together, our domestic network really focuses on all 50 states and all of the territories and jurisdictions and the District of Columbia. A few years ago, SAMHSA took the work of the ATTC network and expanded it to include sister networks that are focused on mental health and prevention. And so this map shows you the broader TTC network. So there's more than 35 centers located all over the country that work sort of hand in hand to provide training and TA for the 3 bucket areas of substance use disorders, mental health, and prevention. So what you're seeing today is a keynote presentation that was taken directly from a day-long curriculum that we developed. The curriculum was under development prior to COVID, and when the COVID national public health crisis began in the spring, we had to pivot, and so we decided that we needed to develop additional components of the curriculum in order to meet the current needs of the workforce. No one at this time is really gathering in person for face-to-face training, and so the working group took the opportunity to develop some virtual products, and so this is one of those virtual offerings. So it's basically about an hour, maybe a little longer, synthesis of the full-day curriculum. So the 3 main things that we hope to accomplish today is really to look at some national patterns and trends in stimulant use, looking specifically at cocaine and methamphetamine. And then we'll dive into some of the short and long-term physical and psychological effects of stimulant use. And then we'll end the presentation with a focus on some of the behavioral treatment interventions that have been shown to be effective when working with people who have a stimulant use disorder. So I will begin the presentation and I'll turn things over to Tom in just a little while. So the first component of the presentation really focuses on the scope of stimulant use in the United States and beyond. We know there's data from a variety of indicators that we look at to really understand how alcohol and other drugs affect the population or affect our communities. And no one indicator tells the whole story. And so what you're about to see is the compilation of data from across some of our major indicator sources to look at things like treatment statistics, general population survey data, student survey data, law enforcement data, et cetera, in the hope of trying to paint a comprehensive picture of what's happening in the US with regards to the use of cocaine and methamphetamine. So before we get to the US statistics, we just want to have one slide that looks at the global picture of stimulant use. And if you look at data from the United Nations Office of Drugs and Crime, they have a World Drug Report that is published each year. We see that in the category of amphetamine type stimulants constitutes the third most widely used illicit drug category. So it's really following cannabis use and opioid use. Now, the type of amphetamine type stimulant that people are using really varies depending on where you are in the world. So in places like Europe and the Middle East, we see a higher prevalence of prescription amphetamines. Whereas in places like the US and Australia and Southeast Asia, we see higher prevalence of methamphetamine. There are different ways to produce methamphetamine, and we'll share a couple of those different manufacturing processes with you in just a minute. So looking into just the US data, this is data from the US Drug Enforcement Administration. And it's from something that is published every year. It's a national drug threat assessment. So law enforcement agencies from across the country are asked to submit data on arrests and seizures and other types of law enforcement stats. And they're also asked by the DEA to say what they feel is the greatest drug threat in their particular local jurisdiction. So if you look at this graph or this map of the United States, what you see is that in many places, especially west of the Mississippi River, we see that the local law enforcement personnel say that methamphetamine is the greatest drug threat that they perceive based upon the data that they gather and based upon their local experience. In many places, heroin is up there as the second greatest threat, but largely, across the western part of the US, we see methamphetamine really is the greatest drug threat. If you go east of the Mississippi River, in places like the New England and the northeastern part of the US, we see predominantly folks saying that heroin and other opioids are the greatest drug threat. And then if you look down into the southern part of the US, you see cocaine sort of has a higher proportion there than you see in the rest of the country. The DEA also gathers data on something on laboratory.
Related to that last slide, I think it's particularly relevant, even though stimulants are not one of the primary drugs in the eastern seaboard. For y'all, where heroin is number one, there's a significant risk of combining stimulants with opioids, and we'll talk about that later. But it's likely that even though opioids are the number one drug problem, that more and more you're going to see people combining them with stimulants, if not using them on their own. And so I think this isn't a time to say, cute, that's not us, but a time to really look at what's happening in the rest of the country and what's coming your direction according to the national.
Thanks, Tom. And thanks for saying that. I actually got a call from a gentleman who's based in New Hampshire, and he had seen Tom and I do this presentation in December for another group at Dartmouth. And he said, he's like, we're not hearing much, we're not seeing much, and we're not hearing much about methamphetamine yet, but we know it's coming. And so they're doing some work in the local hospital system to train their providers on stimulant use, largely methamphetamine, just so that they could be prepared. So Tom's right. It's a coming. Okay, so the DEA also gathers data on methamphetamine lab incidents, which is really the meth seizure data that we see. It's not just meth labs, like it's not just operating meth labs, it's our operational meth labs. It could be dump sites of glassware, it could be seizure of the precursor chemicals, it could be seizures of equipment. And so this data really shows you the domestic production of methamphetamine. So I'm going to show you two time frames. The first time frame is 2004, And then the second map you'll see is from 2017. So back in 2004, there was a lot of methamphetamine being produced domestically, especially in the Western US and in places like Illinois and Indiana and Minnesota and Missouri. And this was really prior to any sort of broad scale control, attempts to control the precursor chemicals. So at this time, it was pseudoephedrine was a precursor chemical that was mainly being utilized. And most of the laboratories in the US were small scale. So they were used for either personal production or for small scale distribution. The finished product was really ounces, not pounds or tons of finished product. So a couple of years after 2004, in fact, a year or two later, the Obama administration passed the Combat Methamphetamine Epidemic Act. And that act was really responsible for limiting the availability of pseudoephedrine and other ephedrine, products that were used as a precursor. So if you fast forward to 2017, the map looks quite different. So you see that there is still domestic production of methamphetamine in the US, but the numbers are much smaller than they were in the early 2000s. Now, this doesn't mean that methamphetamine has gone away, right? In fact, in some places, it's back at levels that are higher than they were in the early 2000s. What happened with the Combat Methamphetamine Epidemic Act is it pushed production of methamphetamine south of the border into Mexico. The precursor chemicals shifted from pseudoephedrine to the P2P method, and the operation of the methamphetamine labs that are in Mexico are considered super labs. So they're producing pounds and pounds or tons of finished methamphetamine that then is trafficked or distributed back into the US using the same distribution networks that the cartels use for things like cocaine and heroin. So numbers are lower, but we are still seeing production of methamphetamine in the US. The DEA also manages a system called the National Forensic Laboratory Information System, and this is data looking at, they call them reports of different types of drugs. So this data is if you're driving on the interstate or on a highway or whatever type of road you want to call it, depending on where you are in the US, and you are pulled over and you have a packet of white powder in your pocket, and your car is searched and your person is searched, and the cops find that packet of powder, and you say, oh, that's not mine, it's my friend's, or oh, that's not what you think it is. That packet is taken and it's sent to a local law enforcement laboratory, and it's tested to see what it is. And so what we've seen through the NIFLA system is that the number of methamphetamine reports has been increasing consistently since about 2008. Okay. You'll notice that 2008 is really sort of the time frame where we started seeing increases across indicator sources. So you're going to see that number pop up over and over again in the next few slides. Tom, did you want to say something? Oh, just making sure.
No, that wasn't me. It was just a weird noise.
Okay. One last law enforcement indicator before we move on. So this is looking at the top drug offense in terms of arrest data. And so if you look across states, you see a preponderance of pink, which is really methamphetamine as the top drug offense. And so in many places, in fact, in more than half of the states in the US, methamphetamine is considered the top drug offense. Whereas in places like the northeastern part of the country, you're more likely to see things like powder cocaine or crack cocaine or even marijuana. But for the most part, more than half of the states are saying that methamphetamine is the top drug offense. So many of you are probably familiar with the National Survey on Drug Use and Health, which is an annual household survey that is funded by SAMHSA, and it looks at lifetime, past year, and past 30-day use of alcohol, drugs, and tobacco. So this data is looking at the number of people who reported past month use of one of those substances, whether it's alcohol, tobacco, or a drug. And so if you look at the top, so basically about 60% people age 12 and older used one of those substances at least once in the past month. Now, what were they using? Well, the number one was alcohol. So about 140 million people age 12 and older said they used alcohol at least once in the past month. Now, that doesn't mean that all of those people would be diagnosed with an alcohol use disorder. It just means that they consumed alcohol at least once in the past month. So it's looking at use as opposed to a disorder, a substance use disorder. Tobacco is number two, with about just under 60 million people said they used a tobacco product at least once in the past month. And marijuana is number three. So about 28 million people said they used marijuana at least once in the past month. If you look for cocaine, it's down there. It's the fifth. It's down number 5. 1.9 million people said they used cocaine at least once, and that's either crack or powder cocaine. And then about 1 million people said they used methamphetamine at least once in the past month. Now, in looking at substance-specific trends, if you look first at cocaine, so now we're looking at past year use of cocaine, so not past month, but past year. And what we see is that in 2018, the significant trend, or the major trend that we're looking at, is that there was a significant decrease in past year use of cocaine among people aged 18 to 25. So that's the young adult population, according to the national survey. The use rates among younger people aged 12 to 17 and among adults aged 26 and older was relatively stable. There were no significant changes in use among those two segments of the population. If you look at methamphetamine, we saw that in the 2018 data, there was a significant increase in the use of past year use of methamphetamine among adults aged 26 and older. Now, it is important to mention that just after this presentation was finalized and released, the new National Survey on Drug Use and Health data was released by SAMHSA. So we are in the process now of doing a data refresh of all of our stimulant curriculum materials to pull in the 2019 data. But we did take a quick peek at it before this presentation, and there were no major changes from 2018, which is the data you're seeing today, and 2019. So patterns, for at least for the stimulants, are largely the same as they were in 2018. So if you look at stimulant use by racial or ethnic group, this is a complicated slide, so I'm gonna walk you through it. So if you go all the way to the left-hand side, that's the powder cocaine data. And we see that whites or Caucasians have the highest percentage of use, so about 2.1%. And then it's followed by Latinx and American Indians and Alaska Natives. For crack cocaine, the highest rates are seen among African Americans, so about 0.7%. For methamphetamine, we see the highest rates among American Indians and Alaska Natives, and the second highest rates are seen among Native Hawaiians and other Pacific Islanders. And then that's followed third by whites or Caucasians. For prescription stimulant misuse, we see the highest rates among whites, followed by Asian Americans. Now, there has been a lot of focus recently on the use of stimulants and opioids together. We're seeing some new patterns in deaths related to stimulant use and opioid use, and we're seeing a lot of reports of people saying that they're using stimulants in conjunction, either sequentially or together with opioids. So we layered in the opioid data just to see what it looks like comparatively speaking. So the previous slide is all those bars to the left. If you look to the far right, what we see with opioid use in general, we see the highest rates among Native Hawaiians and other Pacific Islanders, followed by American Indians and Alaska Natives, and then third, we see whites and Caucasians. If you look, this continues to be data from the National Survey on Drug Use and Health, and this is looking at the past year use of methamphetamine across the U.S. And so just to orient you to what the colors mean, the dark blue, those are the highest rates, and these are population adjusted rates. So the states that are indicated by a dark blue, those are the states that have the highest rates of past year methamphetamine use as compared to other states. The orange is the second highest category, and then it goes, gray, light green, dark green. So again, you see a similar pattern to some of the previous slides where you see higher rates of methamphetamine use west of the Mississippi, with lower rates being seen in the southern US and the northeastern and sort of New England states. So this is data that came out in 2020, and it's from a foundation, and the fact sheet that this data is drawn from was really looking at increases in stimulant use, and it was really focused on the death data, but they included some other additional data that I thought would be good to include here. And so this is looking at, these two graphs are looking at the impact of methamphetamine on the US hospital system. So on the left-hand side, you have emergency department data, and on the right-hand side, you have inpatient admission data. Now, some of you who are familiar with the epidemiology data that's available to us for alcohol and other drugs, there was something called the DAWN system that SAMHSA used to support. It's the Drug Abuse Warning Network. The DAWN system sort of went away for a few years, and it's actually been resurrected in the past couple of years. So we just are seeing some new data coming out of the DAWN system. But what DAWN did is it looked at drug-related emergency department visits. And so this data is looking at that sort of similar indicator source. So if you look on the left, you see the yellow bars are people who came into an emergency department and they were treated and released, but during their visit, they reported using methamphetamine. So methamphetamine was related to their emergency department visit. And you see, again, since about 2008, there's a consistent increase in the percentage of ED visits that were related to methamphetamine. The blue bars are those ED visits that resulted in an admission into the hospital. So again, the numbers overall are smaller. People are more likely to be treated and released than they are to be admitted. But among those people who are admitted into the hospital, we saw increases consistently over time since about 2008 in the number of admissions that were related to methamphetamine use. On the right-hand side, you have inpatient admissions. So again, the major pattern here is that there's been a consistent increase in the number of inpatient admissions related to methamphetamine use. So SAMHSA also administers something called the treatment episode data set, which is data from publicly funded treatment programs. So if you work at a publicly funded SGD treatment program and you receive substance abuse block grant dollars from the federal government, you're required to report your data to the feds on an annual basis. And this is data looking at treatment admissions. When you're admitted into one of these programs, one of the standard admission questions is you're asked to report the primary, secondary, and tertiary substance related to your treatment admission. And so in looking across time, alcohol, opiates, cocaine, marijuana, and methamphetamine are the top 5. And they comprise about 95% of all treatment admissions into publicly funded treatment programs in the US. For quite some time, alcohol was really number 1, was leading the pack. So the highest proportion of treatment admissions were really for primary alcohol use. Not to say that those folks were only using alcohol, but they indicated that alcohol was their primary reason for the treatment admission. We saw that between 2014 and 2015, opiates eclipsed alcohol visits for the first time, and so now opioid related. So opioids are the number 1 in terms of treatment admissions. Cocaine has been sort of on a slightly downward trend since 2007, and we've seen sort of the opposite. We've seen an increasing trend in the proportion of primary methamphetamine treatment admissions. This is the same data, just seen in a different way. So you could see sort of the changes from 2007 to 2017. So I just want to call your attention to the light purple towards the top. Those are the methamphetamine or amphetamine related treatment admissions. So we've seen an increase over time. For cocaine, we've actually seen a decrease in treatment admissions. That's the green bar at the bottom. So there's another data source that's called the Monitoring the Future survey. So this is an annual survey that is administered by a team of researchers at the University of Michigan, and it's a NIDA funded. So the National Institute on Drug Abuse funds this work. And so this has been in existence for many years. And what it is it's an annual survey that looks at alcohol, tobacco, and substance and drug use among 8th, 10th, and 12th graders. So middle school and high school age kids. And there's a smaller sample that follows, there's sort of a longitudinal sample that follows the adolescents from high school, like from middle school into high school into college, and then once they're out of college. But this is data from the core survey that looks at just middle school and high school aged youth. And this is all the stimulant data. So you see, for the most part, if you look across the substances, so for cocaine, crack, and methamphetamine, you see that a higher percentage of 10th graders than 8th graders uses those substances, and then a higher percentage of 12th graders versus 10th graders use those. For other amphetamines, the highest numbers were seen among 10th graders. About 2.4% of the 10th graders said they used a prescription amphetamine at least once in the past month. So I mentioned a little while ago that we are starting to hear a lot about methamphetamine, or maybe more generally, stimulant and opioid co-ingestion. So there are some issues that are related to sort of that co-ingestion of those two types of substances. And what we see is that when someone uses methamphetamine or cocaine and an opioid at the same time, either at the same time or sequentially, we see a synergistic effect that occurs when those two substances are used together, meaning that the result of using both is greater than either alone. When you talk to folks about why they use a stimulant and an opioid together, a lot of people talk about the fact that the stimulant effect, so like the speeding up of the system, helps to counterbalance the depressant effect that they get when they take an opioid. Now, the danger in that is that because stimulants speed you up and opioids slow you down, if you overuse either or both of those substances, it actually results, you don't know you've used too much, right? Because you've got the stimulant, the speeding up of your system, of your heart rate and your breathing from the stimulant. It sort of masks the slowing down of your respiratory system from using the opioid. And so using those two things together actually increases your risk of overdose. So because of sort of the combination of that respiratory depression and the cardiac arrest. And we see, when we look at the data, we see that the most potent effect in that co-ingestion really happens early on, within the first 90 minutes of using. So Ellis and colleagues have been doing some work looking at this relationship between stimulant use and opioid use. And this is a study that was involving people. So the study participants were people who were seeking treatment for an opioid use disorder. So they were seeking treatment because they were using heroin, or they were using a synthetic opioid, or they were using another type of prescription opioid. And when they were being admitted into the program for their opioid use disorder, they were asked about their recent use of methamphetamine. And so it's a longitudinal study, and what we've seen is that over time, there's been a consistent increase in the percentage of people who are seeking treatment for an OUD, but also say they're using methamphetamine. So it's gone from about 19% back in 2011 up to about a third, so 34% in 2017. If you think about some of the practical or sort of real world treatment implications of this issue, one of the things you need to ensure is that you have sufficient naloxone kits available to reverse the overdose of the opioid. And especially because of the interaction effect, it may require more than one dose of naloxone in order to counteract the effects of using those two substances together. When you think about the types of treatment that are most effective for these folks, for people who have an opioid use disorder, we know a lot, and this is not a talk about opioids, but we know that it's important to consider offering medications for addiction treatment, so buprenorphine, methadone, naltrexone, et cetera, to address the opioid use disorder. I'm going to give you one of Tom's secrets from later on in the presentation. There are currently no FDA-approved medications for stimulant use disorder. And so there isn't a medicine. There is not a medicine that you can give someone for a methamphetamine use disorder or a cocaine use disorder, but there are some behavioral interventions that work very well. And one of those is contingency management. And so if you're running a program where you're seeing patients who are coming in for treatment and they're using opioids and stimulants, you want to make sure that you address both of those sort of separately from one another. And we're going to show you some data at the end of the presentation that looks at the use of exercise to reduce both methamphetamine use and to reduce the depression and anxiety that we see among people who are using methamphetamine. So I'm going to give you a few more data slides, and then we're going to go ahead and move on. So this is data. Look, this is death data. So this is looking at the number of overdose deaths involving particular drugs. And so longitudinal data looking back from 2000, we see that, well, we know there's been a lot of focus on opioid-related deaths in the past several years. And so there's been a couple of different waves of the opioid epidemic in the US, and we're currently in wave 3, which is that synthetic opioid wave, largely being driven by fentanyl. So the synthetic opioid deaths are the dotted green line. We've seen a huge, very steep increase in synthetic opioid-related deaths in the past few years. But we've also seen sort of a parallel increase in the number of cocaine and methamphetamine-related deaths. That's starting to gain more and more attention in the literature, in the media, in the just sort of general public. So there is so the next two slides show you the relationship of this death data. So this is data. So we're going to start looking. So this is opioid-related data, opioid-related death data that also involves stimulants. So these are people who died from an opioid overdose, but they also had a stimulant on board when they died. So you see from even in 2008, 2013, and 2018 are sort of the 3 time points. We see that opioid-related deaths that involve stimulants that involve any stimulant have increased. We see that, but what we see here is that the deaths that have involved cocaine have had a sort of steeper increase than those that have had methamphetamine on board. So we're hearing a lot in many places. We're hearing a lot about methamphetamine and really less about cocaine. But if you look at the death data, cocaine is present, and in some cases, it's present in higher levels than it is for methamphetamine. So it's just something to keep in mind in your local jurisdictions. You know what's going on, not to forget about cocaine and about crack. If you flip things around, so now you're looking at stimulant-related deaths, and you're looking at that involvement of opioids. So again, you see overall, we've seen increases among stimulant-related deaths where there's an opioid also present. This slide really shows you the 3 waves of the epidemic. So in 2008, it was really all about prescription opioids, which is that purple bar. Whereas in 2013, it was really about heroin involvement, or heroin was really driving the epidemic in that sort of mid 2010 timeframe. And more recently, we're really hearing most about fentanyl and fentanyl, carfentanil, and other types of synthetic opioids. And so that's really the driving force in this most recent wave of the epidemic. We have seen some brand new data come out that that the number of opioid overdose deaths in this past year is the highest ever. So we were making some great strides between like 2018 into 2019 in reducing opioid overdose related deaths. And a lot of that came from just a major federal focus and lots of funding for providers. But we see that even since COVID, since the COVID pandemic started, we're seeing increases, drastic increases in opioid related deaths again. So that's the data. The day-long curriculum has much more data than what we include here. And so if you're interested, if you're a data person and you want to see more, we can point you in the direction to look at some additional data. But now we're going to sort of take a step back and talk a little bit about the different types of stimulants that we'll be discussing for the rest of today's session. So for the purposes of this curriculum, we're really talking about two types of stimulants, central nervous system stimulants. The first is methamphetamine, and the second is powder and crack cocaine. So you see some images of both of those substances. For cocaine, it's really powder cocaine and crack cocaine are the two major formulations. For methamphetamine, there's a few different types of meth that are being used throughout the U.S. Largely, we're seeing crystal meth, which is very high purity, high potency methamphetamine that really does look like glass or rocks or crystals. We do see methamphetamine powder in different parts of the U.S. It depends on sort of where it's coming from internationally. Base or paste methamphetamine is pretty limited. We mostly hear about it in places like Texas, where it sort of is like in between a powder and a crystal, and it's got this like sticky, gunky sort of consistency. It's like a yellowish, brownish color. And again, we don't hear a lot about it around the country, but we have heard reports of it in Texas. So the Drug Enforcement Administration has something called a methamphetamine profiling program. So what they do is they take the methamphetamine that's been seized and they analyze it to see how strong it is and where it's coming from, or what the precursor, major precursor chemical is. So on the left-hand side, you've got the production routes. And so this data verifies my statement before about there being a shift in production from the pseudoephedrine method, which is that orange line. That has largely diminished almost to zero. The majority of the methamphetamine in the US is coming from Mexico, and it's coming from the P2P method. And so upwards of 95+% of the methamphetamine available in the US is coming from Mexico. In terms of purity and potency, the methamphetamine on the streets today we've never seen it stronger. Like, it's stronger now than it ever has been. Largely, when you test the methamphetamine that's seized in the US, it's upwards of 96–97% purity and potency. So it's very pure. There's not a lot of adulterants, and it's very potent.
So those precursor chemical control laws were really important in taking all those chemicals off the street that were going into our groundwater and poisoning people. But by the side effect of that is exactly what Beth just said. Pushing the production into a different precursor chemical and doing it in super labs, producing by the pound or more rather than by the ounce or more, what they were able to do is refine the process to end up with a better product. So meth hasn't gone away, in part because we have a purer, better product on the street that is actually cheaper than it was when we were making it by the older formulations. So that's why we see things like laboratories going down, but methamphetamine going up as we look at overall rates across time.
Thanks, Tom. So there are some key differences between cocaine and methamphetamine. So on the left-hand side, you've got methamphetamine. It's man-made, as we just described. It has a much longer half-life than cocaine. So if you look at the half-life of methamphetamine, it's about 12 hours. So meaning that it takes 12 hours for half of the drug to be removed from your system after you've ingested it. Whereas cocaine, the half-life is somewhere around 1 to 2 hours. So methamphetamine, the high that you get from methamphetamine is much longer than what you see with cocaine or with crack. The way that it impacts your brain is also different. And Tom's going to talk a little bit more about that in just a few minutes. But cocaine, both cocaine and methamphetamine block the dopamine reuptake in the synapse between your nerve cells. But methamphetamine does one thing in addition to that, and Tom will explain that in just a little while. So we're going to take a sort of right turn and start to talk a little bit about the acute and chronic effects of stimulants. And I'm going to present a few more slides, and then I'm going to turn it over to Tom. So it's important when we're talking about alcohol and drugs and how they impact the user's brain and body. It's important to think about sort of the paradigm shift that occurred a few decades ago in the thinking that was happening around the use of alcohol and drugs. And so Dr. Alan Leshner, who at the time in the late 90s was the director of the National Institute on Drug Abuse, he wrote a seminal article in talking about sort of this massive paradigm shift in thinking about addiction as a chronic relapsing brain disease. And so it was really in the late 90s when we began to think about substance use in a different way. So we started to change the way, the terminology started shifting, and there was a growing body of literature that was showing that it wasn't a moral choice. It was more about the way that alcohol and drugs changes your brain and changes the way that your brain works. And we've made great strides since the late 90s in how we talk about substance use disorders. There is a lot of stigma that remains, and we do a lot of work all over the country to try to combat that stigma that is really present among, the general public, among healthcare workers, even among providers who are caring for these people. So there's a lot of work to still be done, but it is important to recognize the fact that we've made great strides in the past 20, 30 years. So you'll see, I'll mention here that you're going to be looking at data. Some of the research that we're showing you was done prior to the late 90s. And so you're going to see words that we don't use anymore. So you're going to see words like abuse, and you're going to see words like dependence that we don't really use in today's sort of nomenclature because of advances in the way that substance use disorders are diagnosed. So we've gone from the DSM-4 to the DSM-5. The way that we talk about alcohol and drugs is different. So we preserved the language that was used when the research was done because we felt that to change the language is really changing the meaning of the data that we're presenting. But as you think about it as a provider, if you're providing treatment and you're working with patients, you can use today's sort of preferred language in sort of interpreting the results. But you'll see moving forward that you're going to see the word abuse, for example, or abuser. So you're not going to, there will be instances where you're not going to see person first language, but our goal is really whenever possible to use affirming person first stigma reducing language. So this is a cartoon image of your brain, of a human brain. And we know that psychoactive substances, alcohol, cocaine, tobacco, methamphetamine, heroin, impact a variety of different parts of your brain. Where we're going to spend a lot of time talking today is about how stimulants impact our reward center, which is that sort of uneven barbell that's deep within the center of our brains. But you will hear us talk about some impacts on places like the prefrontal cortex, so the sort of front part of your brain that plays a role in executive level decision making and judgment. You'll hear things about coordination and movement, but largely we're going to be talking a lot about how drugs impact that reward center deep within our brains. So I'm going to show you a video that looks at the way that dopamine functions in normal circumstances. So this is just normal dopamine functioning in a person's brain based upon natural reward. So we're not talking about substance use at this point. We're just talking about what happens in our brains when something is naturally rewarding. This, in case you're interested, this video and the one that's going to follow in a few minutes comes from something called Meth Inside Out, which was a documentary series that Emily Myers produced back in the late 2000s. Tom was actually the scientific advisor in the work that she did, and these videos were developed by colleagues of ours up at UCLA, and they're quite amazing to show you sort of what it looks like inside your brain. And so without further ado, this is what normal dopamine functioning looks like.
Our brains are finely tuned machines. Inside, cells called neurons are constantly communicating to shape how we think, feel, and act. Let's eavesdrop on their conversation. These are the ends of two neurons. The one on the right sends a message, and the one on the left receives it. At first, they look connected, but they are actually separated by a tiny space called a synapse, where messages are relayed. What we'll see next is how we normally experience pleasure. The sending neuron contains dopamine, the brain's pleasure chemical. When something good happens to us, this feel-good chemical is released into the synapse, where it connects with receptors. There, dopamine activates the receiving neuron, which in turn conveys the message onto the next neuron, creating a chain reaction that produces pleasure. After the message is sent, dopamine is recycled by transporters to be reused. This conversation repeating itself again and again gives us the feeling of pleasure.
So that's normal dopamine functioning. So anything that feels good is because it's really a result of dopamine being released in your brain. And food and sex in particular are reinforcing because they help for the species to continue to evolve. And so if things like eating and procreating didn't feel good, we may not still be living on this planet. And so this is data that looks at some animal studies that were done to look at the impact of food and sex on dopamine levels in a rat's brain. So these are rodent studies. Looking first on the left-hand side, so this was it was a study where there was a rodent in a feeding box. Rodent was hungry, introduced to food, and what happens is when the rat ate the food, its basal dopamine output level. So the baseline is about 100. So if you look on the y-axis, it's about the baseline level is about 100. Upon eating, the dopamine level increased to about 150. Keep that number in mind because you're going to see over the next couple of slides some differences in sort of dopamine output. So on the right-hand side, you have a different study that looked at the impact of sex on dopamine levels. So this is a male rat and a female rat kept separate. They're brought together and they'll do what rats do. And the result of sex really increased the dopamine level from that baseline level of 100 up to about 200. So if you look at these two things, sex is more reinforcing than food. It causes a higher spike in dopamine levels than what you see with food. So I'm going to stop talking and I'm going to turn things over to Tom, and he's going to take us forward.
Thanks, Beth. Sex, as Beth just showed you, the orgasmic response is actually one of the most pleasurable things that can happen from a natural phenomenon. But what happens when we introduce drugs into the system? Let's go ahead and play the video, Beth.
How does meth change our brain? When we use meth, it enters the bloodstream and travels to the reward center of the brain where it invades the sending neuron. Meth causes dopamine to unnaturally leak into the neuron, then spill into the synapse. Making matters worse, meth blocks the transporters, which recycle dopamine back into the sending neuron. This keeps levels abnormally high, overstimulating our brains. We feel a powerful wave of pleasure. The rush can last 8 to 12 hours from just one dose.
So methamphetamine operates inside the presynaptic neuron by interacting with the little reservoirs that hold dopamine, pushing that dopamine out into the synapse, and then it blocks it from being taken back out. That's what leads to the euphoric rush. Next slide. Cocaine operates similarly, but only in one of those spaces. And that is, it never enters the inside of the cell. It's simply dopamine comes out naturally through the experience, and it blockades the reuptake of dopamine, preventing it from escaping the synaptic cleft, leading to a buildup of dopamine. We think this is why methamphetamine is more powerful as an agent, but also we think that it results in cocaine probably not causing damage to the neurons themselves, given that it operates only in external space outside of the neuron, whereas methamphetamine has been shown to actually do damage to that neuronal tissue in the presynaptic neuron because it operates inside and outside the neuron. Next slide. Now, when we're talking about the experience of on the dopamine system and the experience of pleasure, let's look at a variety of different substances and how they impact that pleasure response. So the upper left-hand corner here is alcohol. Technically, ethanol is the active ingredient in alcohol. And what we see here is a spike in dopamine that's similar to the sexual response. That's that little pink line there on the y-axis. So you get a pretty intense response from alcohol itself. But if this rat went out to a rat bar and got a little alcohol buzz on before he went home with his rat honey to do his business, what we would see is that you get the dopamine response from the orgasmic response coupled with or added to the dopamine response from the alcohol. So the two together produce an even bigger, longer lasting effect than either of them in isolation, which is why we often see things like sexual behavior and alcohol associated with each other. If you move on to the right there to nicotine, you see a very similar kind of phenomenon. Why do people crave a cigarette after a good meal or after a sexual encounter? In no small part because they're elongating and intensifying the dopaminergic response from those activities. When we get to stimulants, we have to change the scale a bit, because the intensity of the response is even bigger. We see with cocaine, for instance, that little pink line at about 200 is the sexual response, and we're way up at about 350. Why do people use cocaine? Because it feels pretty darn good, at least until it doesn't. Finally, we get to methamphetamine, and we have to change the scale even again. And we see again, way down there at the bottom, the sexual response, and way up at about 12 or 1,300 units, the response from methamphetamine. There is no way to equate the kind of dopaminergic response, the kind of reinforcement that we get from using methamphetamine in any other chemical or natural kinds of phenomenon. Unfortunately, in playing with the dopamine system in this way, we have a negative impact on that system as well. Next slide. So what we see across time is a down-regulating of the dopamine system. These show PET scans of three different brains. The brain that's marked control is someone who's demographically matched to a methamphetamine user, but is not exposed to methamphetamine. The more red you see, the more activity there are, in this case showing the reward system that we've been looking at. And so this is natural, normal functioning of the dopamine system. The middle brain, marked meth, is a methamphetamine user just after withdrawal. And what we see is a significant reduction in reds and yellows, and therefore a significant reduction in the activity associated with dopamine in those areas of the brain. The experience, less energy, less feelings of pleasure, etc. The brain on the right, marked PD, is the brain of a Parkinsonian patient, which operates on dopamine in the similar area of the brain. Now, it operates differently than methamphetamine does, but we used to think that that's why we saw the kind of twitchy kind of behavior, the Parkinsonian-like symptoms that we see with someone who's acutely intoxicated with methamphetamine. But early on, no one thought that this was going to be associated with an increased risk of Parkinson's disease. It turns out we were wrong. Next slide. And more recent research has demonstrated that there is a significant increase in risk, from 75% more likely to 300% more likely, of later developing Parkinson's disease among people who have used methamphetamine, even after they stopped using their methamphetamine. And a 2018 study indicated that, in fact, methamphetamine use may be the initiating event that causes the kinds of brain changes that then later leads to a diagnosis of Parkinson. So it may not just be it increases susceptibility, but it may actually be causal in the development of Parkinson's disease. Next slide. So what are we talking about when people use stimulants? In the day-long presentation, we break these effects down into specific effects that are caused by cocaine and then review those that are caused by methamphetamine. But largely, that information is duplicative. So here what we're going to show you is, across both categories of stimulants, what are the general effects that we see, and where there are differences between methamphetamine and cocaine. I'll point those out. So stimulant use looks like excitement. You see all of the things that you see associated with excitement: increased heart rate, blood pressure, respiration, your sense acuity goes up, you have energy for days. It reduces appetite, so people use it for weight loss. It reduces the need for sleep, so you can get more done. And while your reaction time will likely go down, you feel so great, you probably won't notice and won't care. Next slide. From a psychological perspective, we see, again, all of those indicators of excitement: confidence, alertness, increased euphoria and mood, increased energy and talkativeness. Boredom and loneliness go out the window, and the shy, retiring wallflower suddenly becomes the life of the party. And you can literally have sex for days, which is virtually impossible under most other circumstances. So from an acute kind of experience perspective, it feels pretty darn good. But just like with mania, which often for many people who have bipolar disorder feels really good to begin with as they enter into a manic episode, it takes on an uncomfortable edge for many people. So too with stimulants. Next slide. And chronically, what we see is the negative kind of effects of overstimulating the system for too long. So we see some direct effects like tremor and weakness, like sweating, headaches, diarrhea, severe weight loss, direct effects from the drugs. And then we also see some of the implications of how people are using. So cough, sinus infections, burned lips or sore nose, depending on how they're taking the drugs in. And these things together, those things alone can cause significant medical complications, but particularly when paired with the direct impact of the drug. I'll get back to the dental problems in a minute. Next slide. From a psychological perspective, we see increases in confusion, difficulty concentrating, significant fatigue and memory loss, as well as real difficulty and interruption of sleep. We see irritability, depression, and then as it goes on, we can see significant symptoms of psychosis, including hallucinations, paranoia, overt panic reactions, and other symptoms of both visual and auditory hallucinations, primarily associated with psychosis. One of the big questions that we often get is, how do you tell the difference between a psychosis that's primary and a psychosis that is drug caused? And the answer is, you really can't. If you have a really good history that psychosis predates the advent of the amphetamine use or the stimulant use, that's a pretty good indicator. And if it persists for a very long time after the cessation of those, it's a pretty good indicator. But other than that, we have to assume that it's probably stimulant induced until we have evidence to the contrary. The good news is what we do, as we'll see in a little bit, is about the same, whether it's a primary psychotic disorder or a substance-induced psychotic disorder, in that we treat the symptoms with medicines appropriately, hopefully get the person stabilized and away from stimulants, and then continue to look at ongoing management if those symptoms persist. Next slide. I apologize, I have a little bit of a cough and I'm a little bit hoarse, so Beth will take over if my cough gets out of control, but I'm doing okay right now, but I apologize for coughing into the microphone. One of the big risks, as Beth mentioned earlier, is overdose. And in overdose, the drug really is in and of itself dangerous. It causes a few things that are really problematic. One, overheating of the body, and hyperthermia is really dangerous. We know if you have a high fever, you want to get that under control. And one of the side effects of hypothermia is rhabdomyolysis, which is a breakdown of the muscle tissue, which throws proteins into the blood system that can clog some of our organs, particularly the kidneys, leading to kidney failure. The other thing that happens is we just overstimulate everything. And so you can see the brain being overstimulated and that resulting in convulsions and seizures. You see the blood vessels being overworked. And so you see things like stroke, and you see the heart being overworked. And so you see heart attack even in very young people. Next slide. In fact, if you have an organ system, stimulants will very happily take it out for you. The respiratory system, neurologic system, kidneys, liver, the heart, all of those are negatively impacted by stimulant use. And then, as we've talked about, the psychological effects include significant depression, particularly during withdrawal, manic-like symptoms, particularly during intoxication, and psychosis that may indeed be persistent, even if they were never seen prior to the initiation of stimulant use. Next slide. I just thought this was really interesting in that over time we're seeing a significant increase in the number of methamphetamine patients that are experiencing heart failure. Just one look at kind of the impact. And I don't know that there's really a direct explanation for why this is the case, but I wonder if as we've seen the purity and potency go up of the drug, if that's not having a more direct effect on cardiac functioning as well. Next slide. So those are the general symptoms that apply regardless of what stimulant you're talking about. But there are a few other things that seem to be really only seen in the stronger stimulant, methamphetamine. One is ulcerations in the eye, probably because of the increase in blood pressure and increase in intraocular pressure, even more significant overheating and therefore the risk of rhabdomyolysis, as we've talked about before. Weight loss to the point of anorexia, and being really dangerously underweight. And we'll talk about the other three as we go along. So let's go to the next slide. We see a significant increase in skin problems, and there's a couple of reasons for that. One is there's just a drug-induced increase in the oiliness of the skin. And if hygiene isn't maintained appropriately, people who are prone to acne and that kind of stuff, it can cause significant breakouts associated with that. We see a drug-induced increase in sweating, which can lead to similar kinds of complications. But there's also a process called formication, which is actually a psychotic response, which is the experience of bugs or electricity crawling under the skin. And if you have bugs or electricity crawling under your skin, you kind of want to get them out. And the way that you do that generally is by picking holes in your skin so that the drugs or the electricity can find its way out. This can become kind of obsessive, and people will pick off large portions of their skin, leading to large open sores for them and significant skin-related issues. Next slide. From a dental perspective, we see significant decay in teeth. Again, probably determined by a number of different kinds of issues. There's a drug-induced craving for sugary substances, so that can cause a problem. Dehydration, as well as just the drug itself, increases the acidity of the mouth, which can cause dental complications. And in the middle of a 4-day sex marathon, it's hard to remember to stop and brush and floss. And so we think that there's just a significant impact on overall dental hygiene, which leads to tooth decay as well. This and the skin problems are really important. I'm wearing long sleeves today. You can't see what the condition of the skin is on my arms. Someone who's picked off most of the skin on their arms is likely going to do the same thing. And you're not going to know about it if you don't specifically ask about it. When the drug wears off, that's going to hurt a lot. And the way to stop that pain is by using again, or one way to stop that pain. Likewise with teeth. We actually are trained not to notice each other's teeth. It's kind of socially unacceptable. And if you have bad teeth, we learn to hide them because bad teeth are also socially unacceptable. And therefore, if you don't take the time to notice and or ask the individual about the condition of their teeth, severe tooth decay is incredibly painful. And again, another major source of relapse that we can really prevent just by engaging the appropriate health-related services and getting those dental problems addressed. Next slide. Finally, obstetric complications. Both stimulants we know cause problems in pregnancy and delivery. Migraines and seizures in the mother, premature abruptions of the membranes, as well as premature delivery is not uncommon. Eclampsia, preeclampsia, or high blood pressure during pregnancy, which can cause all kinds of complications. As well as an increase in the rate of miscarriage and difficulties in delivery. We also know that babies born to stimulant users are often born with low birth weight for gestational age and or premature, and both of those have been associated with significant complications in development and later in life. In the 80s, we were really, really concerned about the lost generation of cocaine babies. But it turns out as they followed those babies up that when you controlled for environment, that is if they stayed in a drug-using environment, they didn't do very well. But if they got put into a good, or the environment became good and nurturing, they did pretty well. In fact, just as well as their non-exposed peers. Not so with methamphetamine, and we think that has something to do with the neurotoxicity. Next slide. We know that babies born to mothers who use during fetal development show an increase in cardiac and brain abnormalities, lower APGAR scores at the time of birth, and significant neurologic problems, including decreased arousal, increased stress responses, and attentional impairments. If you're interested in prenatal and neonatal exposure, the IDEAL study that was done out of Brown University, IDEAL, it's an acronym that I can't remember right now, but if you just look up IDEAL study and methamphetamine, it's the first thing that comes up. They followed up over the course of many years prenatally and neonatally exposed children and looked at them, and indeed they are showing ongoing effects of exposure to methamphetamine in utero and immediately after birth. Those follow-up studies are still coming out, and so I would encourage you to look that up if that's an area of interest. Next slide. Cognitive memory impairments, it's not good for you. Next slide. It does impact the brain and change the way it functions as well as the way that it's structured. This is a look at whole brain glucose metabolism. The top row, normal brain, so that's normal functioning across the brain. The middle row is a cocaine abuser 10 days post-detox. And you see even 100 days post-detox that the functioning hasn't returned to normal. So the kinds of impacts that we're going to see across a protracted period of time. Next slide. Likewise with methamphetamine, again, we saw the slides on the left earlier with normal functioning showing on the top and a methamphetamine user significantly reduced levels of dopamine activity. But Dr. Volkoff, the current director of the National Institute on Drug Abuse, and her colleagues demonstrated that the less functioning your dopamine system, the more slowed down you are and the longer it takes to get things done. This is really important because if we expect our methamphetamine users to act like every other client that we have, we're probably over expecting. So if they show up late for appointments, or if they miss appointments, or they can't seem to get everything done that you expected them to get done, that might be resistance, but as likely, it might just be an impact of the drug in slowing them down, and we might need to make smaller and shorter kinds of goals in order for them to be able to accomplish. And the less active the dopamine system, the less likely they are to remember stuff, is what that bottom slide there shows. And so if we want them to remember something, we have to give them memory cues. And the more we can make those visual, the better, because there is some data, although it's not conclusive, that visual memory may be less impacted than auditory memory. And as brilliant as we are, when all we do during session is talk and talk and talk with them, and they come back and they say, I don't remember talking about that. Again, we often feel bad. We often feel like they're being resistant. But in truth, that is the neurochemistry that they walk into us with. So writing it down, having them draw a picture, having them write it down so that they have memory cues goes a long way to helping them move from one session to another, holding on to that. Next slide. What this slide basically says is across the board, stimulants impact neurologic functioning. In this case, it's a methamphetamine trial. Next slide. We do have to interpret these data very, very carefully because many of the indicators, even though they're significantly less than their non-exposed counterparts, still fall within the normal ranges. So they're lower, significantly lower, but still within the normal range on those cognitive tests. So we have to look specifically at the test that was conducted, look at the functioning of our patient and interpret how they're doing based on deficits and strengths that they're experiencing, and really look specifically at each domain of neurocognitive functioning, not assume just because they are a methamphetamine user that there's significant impairment in those areas that's outside of the normal range. Next slide. Where that's least likely to be true and where we are likely to see impact in the cognitive domains is in impulsive decision-making and disinhibition, which those functions are greatly impacted, if not largely turned off, in methamphetamine users for a significant period of time. There's also the disinhibition is greater the longer someone has been using methamphetamine as well. So short episodes of methamphetamine use, you may see some of it, but over long-term users, we're going to see even more kind of impulsive decision-making that doesn't make any sense to us. So again, we need to help them structure their world in a significant way so that the number of decisions that they have to make are fewer and fewer and fewer as they're learning to function in the absence of methamphetamine. We make them in our office with them, then they just have to carry them out as opposed to leaving them alone in the wild. Next slide. One of the other things that clinicians are often worried about is the increase in violence. And indeed, there's data that does show that methamphetamine users do engage in violence more frequently than users of other substances. In fact, a twofold increase in hostility compared to people who are not users of stimulants. I don't actually think from my own clinical experience that this is really an indicator that they're more likely to be violent. They're just more likely to go from 0 to 60 much more quicker than users of other substances. And so your ability to maintain calm and to de-escalate situations rather than step into them and kind of respond and mirror that kind of aggressive behavior goes a long way to keeping things quiet in our offices. We do want to use this information, though, to really evaluate carefully whether or not someone is a victim or a perpetrator of violent acts, and whether or not domestic violence has been an issue in their home, because again, we do see increases in violent behavior among these people. Next slide. A variety of different self-reported risk factors. The one that I think is most notable here is among women who have a history of ever having been mistreated or raped sexually. They have a tenfold increase of ending up using amphetamines. And so if you're seeing a methamphetamine user, doing that careful assessment, looking at that backward of their history of sexual violence is really important. I would encourage you to look across the rest of these indicators as well for things that may be important for your clients. Next slide. This says basically the same thing. Let's go on to the next slide. Finally, in this section, I'd like to just say a word about risk of HIV. This is a slide that was done with men who have sex with men on the streets of Hollywood. And at the time, the base rate of HIV was about 8%. What the researchers Reback and Shoptaw did is they went out and they interviewed a bunch of people to find out what their overall HIV and risk was based on their methamphetamine use. They found a group of recreational users. People were using occasionally, not really displaying any kinds of problems associated with their use. And with that, not connected to the treatment system in any way. 23% of those people were HIV positive. They found a group of people who were not in treatment again, but were displaying problems associated with their methamphetamine use, and 42% of those people were HIV positive. In an outpatient treatment setting, so people had already identified a problem and entered the treatment system, almost 2/3 of them were HIV positive. And for those that had made the kind of changes that they needed and moved into a residential setting, 86% of them were HIV positive. Now, this data really indicates, if we use where they are in the treatment system as an indicator of the severity of use, again, it's a broad overgeneralization, but it has some merit, that the longer we let these problems go with amphetamine use and the more severe they get, the more likely they are to come in contact with behaviors that place them at risk for HIV. Now, given that in the Eastern Seaboard, heroin and injection drug use is one of the primary mechanisms of transmission for HIV, as methamphetamine continues to increase as well, I think we're going to see a similar kind of phenomenon, but outside of the MSM population and potentially in the larger injection drug use population as well. Next slide. So treatment considerations, ironically, we don't have a lot of time to talk about treatment, but we don't really need to, because you're going to give them good evidence-based behavioral treatments. But if you're going to do that, I'm going to point you to one or two in particular because they have the most likelihood of success. Next slide. This says basically the brain does heal, but it takes a really long time. For cocaine, it generally takes somewhere probably between 9 and 12 months for the brain to return to fairly normal functioning after cessation of cocaine use. For amphetamine, 1 to 2 years before the brain goes back to normal functioning. So as we teach them how to engage in their life early in recovery, we're actually teaching them skills that they're going to need for a protracted period of time, maybe as long as 2 years, and for whatever symptoms remain ongoing after that as well. Next slide. And as Beth indicated, we don't have any medicines for the treatment that have been FDA approved for the treatment of stimulant use. Now, there are some medicines that people use off-label, and there are some preliminary clinical trials data that show that they may be effective with certain subgroups of population. But as a general rule, we don't have any medical treatments for stimulant use, and so we have to resort to behavioral interventions. Next slide. And if you're going to resort to a behavior, here's the list of ones that have been shown to have some efficacy. But if you, next slide, if you're going to do a behavioral intervention, the one that I would recommend that you do is contingency management or use of incentives to encourage non-use. Contingency management in several meta-analyses that have been done of behavioral intervention for amphetamine use has been shown to be far superior than any other evidence-based practice in helping people stop their drug use or reduce their drug use and to use less during the treatment episodes over the course of time. Next slide. This is particularly true when you combine contingency management with community reinforcement approach, which changes the reinforcers in the person's environment so that not using drugs becomes more reinforcing than using drugs. Next slide. Other behavioral interventions, motivational interviewing, cognitive behavioral therapy, et cetera, have been shown to be effective, but the VEG is kind of non-specific and a bit more difficult to see exactly what you're going to get from those interventions. So in no way are we saying you shouldn't do those. In fact, you should do those to teach people the basic skills that they need in order to live a drug-free life and to cope with the ramifications of their use, but always in combination where possible with contingency management and or community reinforcement. Next slide. So I'm just going to skip over these specific examples and go to that one, which is exercise. And exercise is really critical in that it has been shown independently to work as a treatment for stimulant use. It's been shown to reduce relapse during treatment, to reduce the amount of drugs that people use during treatment, and to have a positive impact on depression and an even more significant impact on anxiety-related symptoms among people who are receiving treatment for stimulant or for methamphetamine use disorder specifically. So anything we can do to incorporate exercise as a component of the treatment that the person provides is highly recommended. We are almost at the end of our time. And so before we give you kind of a link to resources that we have, I'm assuming there are some questions that have come up in the chat, and I'll pause here for a second so we can spend about 5 minutes answering any of those questions. Any that we don't get to, we're happy to respond to by email and let those be circulated to you later. So what questions do we have that have come up?
Yeah, sure. Thank you. The first question there was could either of you explain in a little bit more detail the P2P method that was talked about towards the beginning of the presentation?
I can take
To
that.
really understand it, you need a complicated chemistry degree. But in a nutshell, in a layman's approach, Beth will give you a really good description.
Yeah, so P2P is phenylacetylacetone, which is a different chemical than pseudoephedrine. So P2P, that sort of is the shorthand of the method. And Tom's right. With the pseudoephedrine method, when we were looking at the domestic production of methamphetamine, and it's still not simple, but you could really, like, if you followed a recipe and you got your hands on enough pseudoephedrine and some of the other precursors, battery acid, other types of acids that you would need, you could make methamphetamine in your car trunk, in your bathtub, in your house, in a hotel room. P2P, it just requires, you really do have to have a chemistry background in order to successfully produce methamphetamine using the P2P method.
If only they would use those skills for good, it would be so much better for the world.
And now there's also, like, very recently, there's the P2P method has sort of shifted, and now nitrostyrene is being used as a precursor. But again, it's really produced south of the border in Mexico.
Okay. Are there any tools, tips, or tricks on how to find local treatment organizations that are offering contingency management?
Yeah, contingency management is really a challenge right now, frankly. It's the thing that we need to be doing, and it's federally complicated. Medicaid has a regulation associated with it called the anti-kickback law. And that prevents you from incentivizing anyone from coming into and receiving services if their services are being paid for by Medicaid. The Office of the Inspector General looked at contingency management and made a determination that there are no exceptions for contingency management, according to their understanding. And so they set a cap that you can provide incentives, but no more than $75 per person per year as an incentive. The research that was done looked at hundreds of dollars per month, not $75 per year. And by the way, people go hundreds of dollars a month. It's less expensive than repeated failed treatment episodes, and actually it ends up in cost savings for most programs who implement it. But if they're receiving Medicaid, if they're receiving any services in your program under Medicaid dollars, it doesn't matter where the money for the incentives are coming from, it would violate that anti-kickback law. So we're working really hard with the Office of the Inspector General to try to get those rules changed. Perhaps under the new administration, there may be some more flexibility in that. There's been some early indications that that might be possible. But for now, use of incentives needs to be done very cautiously, and there aren't many programs implementing it widely. What I would think about is how can you use smaller incentives and potentially non-monetary incentives to encourage people to engage in treatment and pro-treatment behaviors. We are doing some preliminary work at UCLA looking at some low-value incentives and how they may be effective, but we're a little ways away from that. So unfortunately, I don't have good news related to that.
Okay, and have ADHD medications been used off-label to treat methamphetamine use disorder, or has it been studied, sort of like a substitute or an MAT?
There was a study in Europe looking at methylphenidate or Ritalin as a kind of a replacement medicine for high-dose methamphetamine users, and it did actually show some efficacy. Obviously, there's some controversy associated with giving stimulants to stimulant users, and none of them have been replicated in this country, and it's never been considered as an option by the FDA. That being said, related to ADHD medicines, kids who actually have ADHD as kids who are treated with stimulant medicines, as long as it's a real diagnosis and the medicines are managed appropriately, they look just like their non-exposed counterparts when they grow up. But if it's just a kid that hasn't been given enough limits and or the medicine is overused, they look like stimulant users. And so ADHD medicine is good, but we want to make sure that those are used appropriately in children. We are out of time, unfortunately, and so I'm happy to stay on if you want to, or we can take any additional questions and answer them by email, and then you can circulate them to the participants after. How would you like to handle that?
Yeah, honestly, we really didn't have much more. So I think if anybody had other questions that maybe they didn't think of at the time, or just have somewhere else to be right now, they can feel free to email them to us at info@ireda.org, and we will be happy to get them over to Tom and Beth for a response. So thank you, everybody, again, for your great questions. A special thank you to Tom and Beth for such a great webinar. I want to remind everyone of our evaluation and CEU process. You will receive several follow-up emails from us. The first one will include a link to the evaluation, and the second will have step-by-step instructions on how to obtain CEUs. Please note that it will take up to 48 hours for your CEUs to become available, because we do have to cross-check attendance records. We would like to specially request that you fill out our evaluation survey. It should take no more than 2 minutes of your time. Again, we want to thank everyone for taking time out of your day to participate today. And if you have any questions, please email us at info@ireta.org.
And
Thanks, everyone. Have a great day.
You are welcome to share the slides with people as well. So feel free to distribute those, and all of those additional resources are available on the slides.
Perfect. Thank you so much.
Thanks, everyone. Have a good day.